Good evening. Hey, everyone. I'm Dr. Mark Brannon. I'm past president of the Princeton Adult School, and I welcome you on behalf of the Adult School as well as on behalf of the Princeton University's Department of Regional Community Affairs. We're really pleased that you're here tonight. I think this will be one of the highlights of this course. If you allow me just a moment of personal reflection in the story, many of you know that I'm a retired physician here in town, but probably few of you know that one time, 40-some years ago, I was the chief medical resident at then Rutgers Medical School, and subsequently did my gastrointestinal fellowship at the Mayo Clinic. And we are very lucky because it happens that just last year, that the dean of the Mayo Medical School, Dr. Gabriel, came here to New Jersey to be the dean of the Rutgers Rumble and Johnson Medical School. When I heard that she was coming, I just thought this would be a fantastic introduction for the people of Princeton to hear what's going on in medical education. And she instantly returned my first request and said yes, she'd be happy to come. So I'm really looking forward to tonight's lecture. Dr. Shereen Gabriel has both an MD and a Master's of Science. She was and is the professor and dean of the Rutgers Robert Wood Johnson Medical School, as well is the CEO of the Robert Wood Johnson Medical Group. There are multiple other titles that I could add very briefly. She is the Dean Emerita, the former Dean of the Mayo Medical School. She was also the William J. and Charles H. Mayo Endowed Professor, and if any of you have ever been to Mayo, you know the two brothers who co-founded Mayo were William and Charles Mayo. She's past president of the American College of Rheumatology. She earned her doctorate in medicine with distinction from the University of Saskatchewan, Canada, and then completed her internal medicine and rheumatology training at the Mayo Clinic in Rochester, Minnesota. Subsequently, she earned a Master's of Science in Clinical Epidemiology from McMaster University. She's had a career-long commitment to education and career development, for which she has received several honors. Dr. Gabriel's research, which is largely NIH funded, has resulted in greater than 250 peer-reviewed original publications. Dr. Gabriel has also served on dozens of governmental committees and advisory boards and many other scientific editorial boards, and is co-editor of the Kelly's Textbook of Rheumatology. She has served in many leadership roles in professional societies, and in 2008 was elected as president of the American College of Rheumatology, which is a college that has greater than 9,000 members. This will be the third to the last lecture in this series. Next week, the former president of Princeton University, Harold Shapiro, will be talking on genetics. And the last lecture will be Catherine Hempstead, who is the director of the Robert Wood Johnson Foundation, and we'll be talking about how do we pay for all of the things in medicine. But tonight, the topic is the transformation of medical care in America, and please join me in welcoming Dr. Shereen Gabriel.
Thank you very much. That was a very kind introduction, overly kind, and it's really my pleasure to be here. Hopefully everything will work. Sorry, I'm just going to get myself logged in here quick. Okay.
Technology here so that you don't hear all that feedback.
This is fine. Can folks hear me pretty well?
No.
We tested it 10 minutes ago. It worked perfectly. Perfect. Okay, so we'll try this again. So thanks again for being here, and thanks for your interest today. I'm going to talk a little bit about how medical education is changing in America. So what I'll try to do today is, first of all, address why it's important, actually imperative, to re-engineer healthcare delivery in America, the way we all receive care. Introduce the notion of the healthcare delivery sciences, we call it, sort of a new discipline. And then give you some examples of institutions, including my prior institution, where we begin to develop programs in the science of healthcare delivery, and then maybe something about what we can do here. So as I think everybody knows, life expectancy and healthcare has been improving. And this is just a figure of, as you see on the vertical axis, life expectancy in years, by dollars on the horizontal axis, and all the various dots there represent countries in the developed world. And here we are over here in the US, and I guess I can just use my point. I don't know if I can point, but I don't think I need to point. So to your right is where we are in this country, and I think many of you know that the US spends more on healthcare than virtually any other developed nation, even adjusting for wealth. We're just not getting value for the money that we spend on healthcare. There are also some other problems with our healthcare system, including medical errors. And I like this picture because it sort of gives you an idea of the problem we have with medical errors. So the number of deaths per year that occur because of medical errors in the US is equivalent to one of these big things crashing every single day, a Boeing 757. There's also a great deal of waste in healthcare. The Institute of Medicine, which is a body of senior distinguished physicians from around the country, has done a lot of study on this, and this was a nice report that looked at waste in healthcare. And their byline is, it's officially a mess. So the United States, and these are old data, 2009 data, wastes $750 billion, according to this detailed study in 2009, and as many as 75,000 people who died back in 2005 really would have lived if the kinds of care that they needed was provided. So it wasn't care that we didn't know they needed, it's just that we didn't connect the right people to the right care. And this is just an example of the sources of waste in U.S. healthcare, and you can kind of see what the big circles are. So unnecessary services, services that are provided that really aren't indicated. Inefficiently delivered services, another really big piece. Excess administrative costs, another big piece. And then, prices that are too high, fraud, missed prevention opportunities, a little bit less. So really major sources of error in this country. This is an interesting analysis. It was published in Health Affairs, a leading journal that studies these things, and the topic was amenable mortality. So deaths that were avoidable, basically, deaths that modern healthcare would know how to prevent if, again, we connected the right person to the right care. And this is, oh dear, can't remember which one is males and females. I think this is males and females. And purple is France, green Germany, blue UK, and red US. And you can see that amenable mortality is significantly higher in people in the United States compared to others in the developed world. A little bit more on this. This is another major report that was published on this topic, again from the Institute of Medicine, the National Research Council of the Institute of Medicine, and basically the conclusion is that the tragedy is not that the United States is losing a contest with other countries, according to this report, but that Americans are dying and suffering from illness and injury at rates that are demonstrably unnecessary. And a lot of folks say, well, you know, once you adjust for income and health insurance and smoking and obesity, that all comes out, but in fact it doesn't. Americans still fare worse than people in other countries, even when the analysis is limited to non-Hispanic whites, people with relatively high incomes and health insurance, and non-smokers, and who are not obese. So there's something more going on here. And the problem is the way we deliver care. So care in America is error-prone and fragmented. Craftsman style, by that I mean, you know, it's sort of dependent on the individual physician rather than a standardized systematic approach. Enormously expensive, poor value, with costs that are locally driven. And there seems to be actually an inverse relationship at times between dollars and quality, and of course our payment system is messed up. The solution, at least many of us believe, is patient-centered, science-driven, integrated healthcare system. So patient-centered, all about the patient, grounded in the fundamental medical science, and integrated so that it's systematic and produced and delivered rather by teams, not just individuals. And this is just a little bit more on that topic, and then we'll get into why education needs to change, educating physicians. This is Michael Porter from Harvard, who's written a great deal about this. And he says, in the rest of the economy, huge gains have been made by better integrating and coordinating all activities required to serve customers and other service industries. Seamlessly coordinated networks and partnerships have replaced adversarial or arm's-length relationships in delivering value for end users. And healthcare is long overdue for such a transformation. And again, if you're interested, I'd really recommend Michael Porter and Elizabeth Teesberg's books. There have been several. This is just one of their articles. And I'll give you an example of kind of what he's talking about. When we think about online retailers like Amazon, they can find your order in warehouses the size of 20 football fields. But can we actually find the right equipment for the right patient every time? There are multiple errors around this particular problem in healthcare. Global courier services like FedEx can track your package from Shanghai to Chicago. You know, they know exactly where it is any moment when you go in there and look at it, or look for it. But when we think about your lab tests, can we actually track those tests anytime, anywhere for all of our patients? And when you think about the hotel industry, hotels use predictive analytics to determine availability and rates. And we are challenged to forecast appointment availability. Patients are often waiting for long periods of time, and it's very difficult to manage appointments in healthcare the way hotels do it. So, in fact, businesses in the service industry, and medicine is a service industry, have re-engineered themselves in the 21st century. And this notion of the science of healthcare delivery is simply re-engineering healthcare for the 21st century. These are some additional quotes from somebody who's thought a great deal about this, and I'll share his name in a moment. And he says, we cannot address the ever-increasing, unsustainable costs of healthcare without getting to the foundation of how care is provided. So here again, I'm not talking about discovery, but really the way we provide care. Nor can we achieve the social and moral goals we share, that is care that is safe, appropriate, effective, and high quality for every patient in every community without rethinking and redesigning care. And he says real improvements require a multidisciplinary approach, again, this team-based approach that will bring the best minds to focus on the problem. And when he says, and when we think multidisciplinary in this healthcare delivery science concept, we don't talk just about healthcare specialists, but experts in management, systems thinking, engineering, I guess the building we're in now, sociology, anthropology, economics, medicine, health policy, and other fields really need to come together to fix the system. And this is Dr. Jim Kim, who's currently the president of the World Bank. Dr. Kim also points out to the enormous investments that have been made in global health. And these investments, you would think, would have led to what we might have called a science of implementation and execution, but this hasn't really happened. In the US and in the developed world, we focus so much on discovering new medications, discovering even new tests, on the basic sciences of disease and the development of new treatments. It's all about developing that new treatment for cancer. But what we have not focused on is the enormous complexity of delivering care in a way that keeps people healthy and that provides high quality care at a low cost. And in fact, it's really not a lack of interventions, of discoveries, that's the main obstacle to faster progress towards Millennium Development Goals. It's the low levels of use, especially among the poor, low levels of use of things that we already know work. So globally, the use of effective interventions, for example, for child health is below 50%, and in many countries it's much worse than that. And if we were actually able to use all known interventions, everything that we know works, achieving 99% coverage, so for everybody who needs those interventions, we could avert 63% of child deaths and 74% of maternal deaths. So that's just optimally implementing the interventions that we already know work. So Dr. Kim actually was president of Dartmouth before he was president of the World Bank, and he pushed this when he was in Dartmouth at Dartmouth, and he actually started an institute called the Dartmouth Center for Healthcare Delivery Science, and he talks about the fact that the missing piece in healthcare reform is healthcare delivery science. And again, the notion of bringing the best minds together across a number of fields, not just medicine, but management and systems and engineering and humanities and economics and health policy, and to be sure that we can make healthcare, that is really the way to be sure that we can make healthcare the best that it can be. Again, the problems, as he points out, are not primarily those of medical knowledge or even political will. It's all about management and execution, achieving better outcomes for lower costs that's scientifically, ethically, and managerially sound. And it's really that last piece that is missing. Another institution that I was a part of is the Arizona State University, which started not so long ago as a master's degree in science of healthcare delivery. And at that institution, they believe that a strong foundation in healthcare and healthcare delivery science is important to contribute to patient-centered care. And they used again, they brought these other disciplines together, health economics, policy, health disparities, to create a case-based, solution-oriented approach. And I've got, I think I already said this, the ASU program, just to give you a sense of what that program contains. These are some of the topics. So they talk about healthcare systems design, health promotion, leading organizational change. There's a lot in health policy and health law. There are capstones and so on. So just to give you a sense of what these disciplines look like. And I'll just, this little clip is from Dartmouth, but I think it just gives you a much better sense than I can of what this program can offer.
Our system is in for a real change here in the next 5 to 10 years. I don't think anybody knows exactly what that's going to look like.
The major problem with healthcare is not one of the underlying science. The problem is one of organizing and delivering the care. The potential for bringing management, business, research, and knowledge together with what TDI knows about the way care is actually delivered and the way they study it. And then into that mix, you take Dartmouth's commitment to learning excellence and to doing educational programs at the very highest level. Not only tremendous capability and potential for understanding what happens out there in the world, but for improving it.
This is the standard of care, absolutely. Okay, you're gonna go first on 5. We can start. Now, in this particular line,
Teaching is outstanding. I just felt that it was very personal, very relevant, and very current in style.
I think that's part of the reason why Tuck has such a great reputation is the ability of the professors to engage and get students to learn on a different level.
it looks odd. If we compare the standard of
Dr. Chomsky really energized me and really made me want to delve into the material, and I think I saw evidence of that the next day when I went on to the virtual learning environment and suddenly realized that a bunch of my classmates had already started doing problem sets that were due in 4 or 5 days.
The hybrid learning mode is really conducive to being able to fit it into your schedule and being able to personalize it. It's a fantastic opportunity to learn while you're practicing.
So these are physicians being taught by the top
Day-to-day
school
in healthcare
professors.
administration,
Top
you
business
don't
schools.
get this discrete period of time where you can interact and talk about the bigger questions, the bigger processes. So the idea that you can have a group of physicians and administrators working on projects together and trying to reconcile their approach is half the value of the program.
It's really important to have executives at this level have an appreciation for the tools and techniques. So when somebody says, we need a resource for this, it becomes a priority because you understand intuitively how important these tools are.
If you're in an industry that's changing this rapidly and this dramatically, what do you want? You need the human capital within your organization to drive change.
Learning a common language that we can communicate with the business decision makers on one side and the patients on another will really tighten up the process.
It's not always going to be an easy way to do it just through national legislation or a big overarching change. And I think there's some imperative upon each institution to create some of that change.
We want smart people who can say, this is where I think we should be positioned because it's going to maximize our options, and this is how we're going to get there, and I'll lead us there.
My dad has always told me that there's 2 things you can do in life. You can either sit on the sidelines and complain, or you can go out and actually do something about it.
So again, it gives you a sense of what they do at Dartmouth. And at Mayo, when I was there the last few years as dean, I worked with a center that was created there called the Kern Center for the Science of Healthcare Delivery, and what I did there was launch the education arm of that center. So it's a similar idea to what Dartmouth had. We collaborated with them a little bit, and we always kind of competed on who had the idea first. They called theirs Healthcare Delivery Sciences. We call theirs the Science of Healthcare Delivery, but whatever. But again, it applied innovative science and data to evaluate quality, safety, and value of healthcare. Again, the way healthcare is being delivered to improve real-world experiences for patients. The Science of Healthcare Delivery initiative at Mayo really brought science to the healthcare delivery process through study, through application of process improvement, management systems, business knowledge, systems engineering principles to the way we deliver care, and again with the goal of improving quality, improving safety of care, and improving the service and the value we provide for our patients. And I'll just give you a clip from what we talk about at Mayo, how we described it at Mayo, similar ideas. Very attractive woman on this clip. You'll see in a minute.
In 2015, Mayo Medical School is partnering with Arizona State University to take a bold new approach to medical education through a comprehensive Science of Healthcare Delivery curriculum.
The science of healthcare delivery is critically important to the next generation of physicians. It will provide them a new fund of knowledge, new skills, and new attitudes that will help them better serve patients and populations.
How do we maximize value from the patient's perspective? How can we ensure that patient care is coordinated and not
That was my
fragmented?
boss at the time.
How do we make sure we're providing ideal care based on the best science? Focusing on these challenges requires a fundamental change in the way medical students are educated.
teaching the science of healthcare delivery for our medical students and really providing them expertise in this area, I believe will differentiate them among the other medical students in the country and will help them become the physician leaders of tomorrow.
Improving healthcare delivery is more important now than it has ever been, given the universal awareness of the many challenges in U.S. healthcare today.
So we have a paradox in the United States. We have some of the best examples of healthcare in the world, actually, and we have mediocre and very poor examples of healthcare, so that the United States, as a country, on average, is not getting the outcomes, the safety, and the service for the amount of money that we're spending. That's the number one problem that we have in this country.
Out-of-pocket expenses are higher than they've ever been, especially for a commercial patient or an uninsured patient. And so I don't know what I'm coming in to receive, and oftentimes the caregiver can't tell me how much it's gonna cost. And so if that person comes in and gives me 5 minutes and just tells me what they're gonna do, not why they're doing it, it really seems like they're cheating me out of the opportunity to make a choice.
We need to change the way we're providing care. We have to change the way we are measuring how we provide care. We need to change the way we think of taking care of people so that we can keep them healthier and in better overall medical condition for their whole life.
The Science of Healthcare Delivery curriculum will help doctors and other medical professionals improve the patient experience. It leverages the combined strengths of Mayo and Arizona State University to create comprehensive content informed by real-world experience.
The exciting thing about Mayo and the SU working together with this new curriculum in the Science of Healthcare Delivery is that we will merge new systems and new ways of thinking into a new design which will produce fantastic new outcomes.
Imagine bringing together the teacher scientists of Arizona State University from their many different academic disciplines such as the social sciences, humanities, engineering, business, and more, and combining that with the physician scientists of the Mayo Clinic.
The most innovative organization in healthcare in the country, Mayo Clinic, now links up with the country's best example of a new, high-speed, highly innovative, highly adaptive, flexible university. Bring those two things together, and out of that you get the opportunity for complete new designs and complete new outcomes related to healthcare and health solutions.
The curriculum is carefully designed to address the factors that influence the health and delivery of care to patients from a number of perspectives.
We built the Science of Healthcare Delivery curriculum around 6 concepts or domains which we believe are critical to preparing the next generation of physicians and physician scientists to meet the challenges of American healthcare in the future. Person-centered care looks at healthcare from the perspective of the individual patient, that critical relationship between patient and physician.
It's taking a much more individualized or personalized approach to the care of the patient.
Students will learn how to reach out to patients, communicate with patients across literacy barriers, cultural barriers, lifespan barriers, and we'll also learn things such as shared decision-making, how to advocate for individual patients regarding their care.
So in population-centered care, students are learning such things as social and behavioral determinants of health, health disparities, health inequities.
Students will really focus on the things that impact the health of a population and how physicians can intervene in a positive way to improve population health.
Another critical dimension is high-value care.
In this particular domain, students learn about how to optimize patient outcomes, as well as the patient experience while minimizing the costs of care.
Helping medical students learn the concepts of evidence-based medicine, improving quality, reducing errors, all of that's in that high-value domain, and it's vitally important that we train our medical students to learn this when they're in their formative years.
Health policy, economics, and technology will focus on external forces and systems that influence the practice of medicine.
Things like governmental policy, governmental legislation, health law, health economics.
We are using more and more technology to help take care of patients, to improve the care that we deliver. And so really having our students understand the fundamentals of electronic health records and other ways in which we use technology to improve patient care is very critical.
Team-based care is about ensuring that care is not fragmented,
We teach students how to build effective, coordinated, high-performing teams within healthcare, and what the role of the physician is in each of those teams.
Leadership focuses on skills that physicians and medical professionals need to ensure healthcare teams provide the best possible care to their patients.
We provide some personal development for our students to develop their own leadership styles in order that they could lead high-performing teams.
How to manage people, how to inspire and motivate people, which are very important in healthcare.
The skills and knowledge learned through a traditional medical education are still vitally important. But to be successful, 21st century healthcare professionals need more.
With all the changes in medicine, I think it's apparent to many of us that the time is right to change the way we educate our nation's physicians.
The science of healthcare delivery will help you think about how you create value, safer care for your patients at lower cost, and making sure that they get the best possible experience. That'll help you be a better physician.
You're going to be empowered in science, in medicine, in economics, in engineering, in systems engineering, in problem solving. Don't worry about it. It's going to be worked out. It's going to be seamless, and you're going to be unbelievably empowered.
And to really establish yourself as a leader in this field, I think that this is the program, the best way to be a real systems game changer.
So this was the way we put it together at Mayo. As you can see, there are the 6 domains, and we created programming throughout the 4 years of training in medical school, which is already a pretty full 4 years. So we had to do a little bit of juggling and move some things out and create some space. And I'm just going to highlight those 6 critical areas just briefly. Again, you heard about some of this: health policy, economics, technology, health law, health financing, clinical informatics, so critical in medicine these days, healthcare information technology, that was an important segment. Population-centered care, I think all of us hear about population health, so the focus not only on improving the health of individuals, but improving the health of populations, so those are things like the social determinants of health, culturally competent care, and surveillance and measurement gaps in the health of populations. Not forgetting person-centered care, health coaching, counseling, communicating across cultural barriers, languages, and so on. And then team-based care. How can we bring a team of experts together to really focus on providing individuals the best care that we can possibly provide, and what are the roles and responsibilities of members of the team? The physician isn't always the leader of every team, and that's something that we teach our students. And then again, high value care, that's providing the best care at the lowest price. Evidence-based medicine, identifying gaps in our systems, tactics for improving quality, improving safety, including things like systems engineering and human factors to really understand the source of errors to begin with and begin to change those. And then leadership, things that many of us didn't get in medical school. How do you effectively lead teams as a physician, or how do you effectively become an effective member of a team? Leadership skill development. So it just gives you a sense of what those are. So that's really what I was going to present. Just a few final thoughts. There's a major transformation underway in healthcare today. I think all of us are aware of that. Healthcare delivery is being re-engineered, and these changes require an analogous transformation in the way we educate the next generation of physicians, so that they can not only move that transformation forward, but hopefully accelerate it, move it forward even more quickly. New educational models are needed, and these models increasingly require interdisciplinary collaboration, as I mentioned, across a variety of disciplines that typically haven't had much to do with healthcare, like business and management and engineering policy. And I would say institutions like this one, like Rutgers, are actually uniquely positioned to contribute in this arena in ways never before possible. As you saw in the little clip from Mayo, I had to find a partner in ASU to help bring some of those disciplines to medicine. You know, Mayo Clinic doesn't have a university, so the notion, you know, where am I going to get the economics expertise, the health policy expertise, the law expertise? I have to find a university to partner with. But a place like Rutgers now has all of it together, and certainly this institution where we're sitting certainly has a way to contribute to healthcare that perhaps didn't exist before. And the last thought I'd share with you, which isn't a surprise perhaps, but we're developing a very similar program at Rutgers Robert Wood Johnson Medical School. So I'll just thank you for your attention and stop there and perhaps take a few questions. Thank you so much. So any thoughts or questions or reactions? Yes, sir.
Yes, you mentioned that things will have to be moved out of the medical curriculum to make room for this, so what is being moved out?
Well, I mean, not moved out, maybe sort of changed. So there's always, public health has always been part of medicine, for example, and we've changed that so that there's more of a focus on population health, a little bit more of a focus on some of these healthcare delivery sciences. You know, medical education is pretty heavily regulated, so there, you know, you have to have so many weeks of this and so many weeks of that. At Mayo, what we did was actually shrink the required curriculum to a minimum, and that's challenging because medical school is challenging enough, and tried to fit some of those other some of the other coursework in. The other thing that we did at Mayo was provide students an option of taking an extra year and earning a certificate in healthcare delivery science, or even earning a master's in healthcare delivery science with an additional year. So we really varied it depending on the students. Some students, especially those who came in with a fair amount of background, could manage an integrated program. Others would take some extra time. Yes?
We hear about drugs and drug use in the country. And that's really a cultural problem as much as it is a medical problem.
Yes.
And I don't know whether that drug use is a major factor in the decreased value we get from medical services.
Yeah, well, and I think that's why in programs like this, there's such an emphasis on social determinants of health. You know, healthcare has a relatively smaller impact on outcome than, you know, poverty, for example, or some other determinants that are really more social than healthcare, maybe that would predispose to drug use. And without students understanding that those variables are as important and often more important than the medicine that you choose, they're not going to be well prepared to address them. So I think you're exactly right, and that's the kind of thing that we teach in the social determinants of care, of healthcare. I'm not going to remember who was first, but I'll maybe go from the bottom up. Yes, ma'am.
This sounds like quite an effort at revolution in not just providing health care, as Dr. Young now, but economically, it's going to have to change the practice. How long is this going to take? How far along are you?
Well, so I mentioned a couple of institutions that are moving forward doing this. There are others. And it's happening right now. It's happening to a greater or lesser extent across a whole variety of institutions. I mean, one example, I mentioned the words health systems engineering a couple of times, and the study of how to provide ICU care, intensive care, better. It was found that the way you design an ICU is actually critically important to patients' outcomes, which again isn't something that we would normally think of. So it's just a matter of trying to bring the right disciplines to bear on, optimally providing the care to people. How long is it going to take? It's hard to know. I mean, it's already underway. It's accelerating. And I guess my argument is we need to make sure that this next generation comes into it much better prepared than we were, because we didn't get any of this kind of education. And so providing the next generation of physicians with this kind of education, hopefully they'll be able to accelerate the process. But it's happening now in most major medical institutions. This education program, we're starting it now. So I'm starting it now, but we're rolling it out.
As a part two to that question, since Dartmouth-Hitchcock was one of the programs,
Yes.
and it happens to be a very small, my son went to Dartmouth, they live up there, and that's their health system.
Yeah.
And so we're very familiar with it. I'm curious, are there actual outcome measures to show whether, since Tuck has been a noteworthy institution in and of itself as business management, as has Dartmouth-Hitchcock for a very large area of New England. And so do we have actual benchmarks and benchmarks, measured, quantifiable studies demonstrating that this method is actually affecting, the outcome? And I just give you as an anecdote, my daughter-in-law's mother has been cared for at Dartmouth-Hitchcock, and it took 4 hours for them to locate her medication for her cancer treatment. She's been a patient there for some time. And that is with my son as an attorney and my daughter as daughter-in-law as a financial manager, and them knowing all the people in place because they all sleep there and hike there. So it's challenging is what I'm saying. And are we seeing that we're on the right path rather than going in a direction that, there may be a couple of other things that we're missing?
Yeah. So you're exactly right. And I mean, both of you are exactly right. This is a long path, and Mayo Clinic's been on this path for a long time, and the kinds of the scenario that you described happens there all the time. Sorry, still happens there all the time. It happens everywhere. But without a sort of a disciplined approach to trying to organize care differently, and you're absolutely right, and this approach is all about measurable outcomes. And so there's emerging publications, there are a lot of publications. The ICU example is just one of them, looking at, okay, when we re-engineer it this way versus engineering care this way, which produces the better outcomes. So there's research out there. It's not on the approach, it's in specific disciplines. So you have to study it, like in the ICU, in the emergency department, in diabetes care, and so on. And so it is a revolution, it is a transformation, and it's going to be, at times it'll be 3 steps forward and a step or so back as we, do something that then we learn maybe that wasn't the right way and we need to redirect. So, and again, that just speaks to the importance of educating people and at least giving them the tool, giving the next generation the tools so that they know how to address these issues.
Well, my second part to that question is
Okay.
I studied Kaiser to see if their approach, because you have a model that's been in place for 30, 40 years.
Yes, sir.
Seems to me there's an elephant in the room that's being totally ignored.
Okay.
That is the enormous amounts of money being spent on defensive medicine. I say this with some background knowledge. I've been a lawyer, including a trial lawyer, for a long time. And I'm told that up to $750 billion every year is being spent on defensive medicine because doctors are afraid of being sued. And we know that medicine is about as much of an art as it is a science. Second, about physician-patient relationships. My daughter and son-in-law are both physicians, and I'm told by them and by others that the relationship between physicians and patients has suffered tremendously in the last 10 or 15 years because in order to get reimbursed, doctors have to fill out enormous
They're doing this.
forms.
Looking
They
at the
come
screen
in
often.
to the, and they got 12 minutes to spend with a patient. And in order to get reimbursed, they have to put the diagnosis into one of 1,000 different categories. So they have very little time compared to what they used to have. Actually talking to the patient.
So that,
That's my comment. It's
Yeah,
not a
yeah.
question, it's a comment.
But that's exactly right, and that speaks to the importance of re-engineering the way we deliver care. So some places, some emergency rooms, for example, have scribes, where somebody who has a little bit of medical training sort of follows the doctor around and does all of this entry. And the waste, just one comment about the defensive medicine. That was also studied in that waste in healthcare analysis, and it's actually it's an awful lot of money, but it's actually less than some of the categories I showed. Yes, ma'am, up there.
So we're, in a hot political race, and everybody keeps complaining about the current medical system from the political standpoint, the medical system from a political standpoint. So what is the integration that these programs, your program, Rutgers, at Mayo, and wherever it's being done, instituted, how is it integrating with both insurance companies and the politicians? Is there, first of all, is there an integration? And second of all, if so, how is that integration happening?
Well, I'm not sure there's much integration with the politicians. I won't say more about that. But insurers, I think, it's an important issue. I was one of the important initiatives along these lines was something called the Patient-Centered Outcomes Research Institute that came out of the Affordable Care Act. So it was a product of the Affordable Care Act. And the nice thing about that institute that I was a part of was that it brought together all the stakeholders in healthcare, insurers, not only insurers, but pharma, big drug companies, as well as the providers of care, as well as patients, as well as patient advocacy groups, and really got them all around the table to try to initiate and develop some of these very initiatives. So have we integrated with insurance companies? No, but there is at least a recognition that we're all stakeholders in providing the best care, and there are entities and groups that have come together to try to do that. So that's a roundabout way of saying we recognize the problem, but we haven't quite gotten there yet. Yes, sir.
In your early slides, you had some wonderful depictions about FedEx and Amazon, showing best practices. Have you been able to actually tap into them rather than the academic centers to come and have them share their expertise with you?
Yeah, no, I think you're exactly right. So at Mayo, we had, didn't we have the FedEx? So we had some of those business leaders on our boards to try to, okay, so what did is there something that we could learn from FedEx? I think we had FedEx, right? Google. And Google on our board. So I think healthcare institutions are increasingly reaching out to sort of business leaders that have figured out how to provide service in a standardized way more effectively to try to see what we can learn in medicine. I mean, the airline industry is another one. I mean, their error rate is it's not perfect, but but it's really a fraction of what we have in healthcare. Okay, yes, ma'am.
I don't see how you can provide good patient-centered care without time. I had a friend recently who went to the Mayo Clinic, very medically complex. They rushed her through all the appointments. She was exhausted. She wanted to tears, and their solution for that was go to a psychiatrist.
Oh my goodness. Oh my goodness.
Medicated for depression. It's
Sorry.
a horrible experience. And you say you're improving things in the Mayo Clinic education section, but it is not showing up in
Well, I'm sorry to hear that. Yeah, time is an issue, and I think until we remove some of the waste that's currently draining the system of resources, we're not going to be able to address that problem. And so the current way to address that problem, there's not enough money in healthcare, so they whip the doctors to work harder. Well, instead of seeing this many patients, you have to see this many patients in the same amount of time, and then the quality of care goes down. And so I think that's the wrong way. You're just doing the same thing. You're just making the same making the same mistakes every day. The whole system really needs to be re-engineered. So a group called, I'm not going to remember the name of this group now, but they use a population health approach to take care of large numbers of people with diabetes, where you have a diabetes specialist and a lot of diabetes nurses that are connecting with patients in their homes to try to prevent them from coming into the hospital. And so that would provide more time for somebody, perhaps like your friend, when she does show up to the hospital, then there isn't this drain of resources on folks that really don't need to be there. So that's where population health and just different approaches to healthcare work. Yes, ma'am.
My question has to do with the healthcare costs. And in the development of this system that you just described, was there any discussion about the personal responsibility of the patient once they leave the hospital to do something as simple as follow the instructions on taking the medicine, for example, if they're diabetic, in order to reduce the return visit, the number of return visits, and reduce the health costs of treatment of that particular patient?
Well, yes and no. We probably need to do more along those lines. But in this particular approach, we have like panels of patients or advisory groups of patients that sort of help us do a better job to educate the providers. And it's a two-way street, as you say. So some of the approaches, I'm kind of forgetting the terminology, but some of the approaches, involve jointly physician and patient together, jointly making sort of having a contract almost on how are we going to improve your outcomes together. Your responsibilities as a patient, my responsibilities as a provider, and we work together. So a shared decision-making approach. So that brings the patient much more in charge. But in terms of how patients globally can reduce the cost of health care, you mean their own health care or in a global sense?
No,
their own health care. So I think that's where shared decision-making comes in. So it's not just my job to improve your outcome, it's our job to partner together to improve the outcome. Yes, ma'am. That requires time. It gets back to, can we remove enough waste out of the system to really have the time we need to do this right? Yes, ma'am.
Last week, we heard from someone who spoke about the decline in the number of people who have gone into gerontology, and given the population trends to older populations, I wondered whether that was something that was being addressed in schools. And the other point that was made was that New Jersey had extraordinarily high expenditures, and the last 2 years of life with high technology solutions, highest in the country, I guess.
Yeah, and that's, you may have seen in that waste analysis, one of the biggest chunks was providing care that isn't really needed. And so part of what has to happen is a culture change. Some of the care that's provided in, the very, very end of life, and it's everywhere in this country, and it's much, much higher than in other developed countries, is not going to change the outcome at all. But we're sort of cultured to do just everything we can until the very last minute, sometimes creating pain and discomfort that really is completely unnecessary, not to mention costs. So that's sort of a culture change that has to happen in our society, and that is the biggest chunk of waste in our system. And again, that needs to be removed so that we can focus on what's really important. And the other issue that you mentioned was gerontology and primary care, which are the lowest paid some of the lowest paid specialties, I think the lowest paid specialties. And there is some reform underway now to sort of decrease the some of the very high paid specialties that probably could do with a little bit less and elevate those at the lower end. Again, that is what happens in Europe. And so that disparities between compensation of a neurosurgeon and a gerontologist don't exist to nearly the same degree in Europe and Canada. Yes, ma'am.
Could you say something about how you would concretely do, what you would do in the course of medical education for the next generation to achieve something like these leadership? I'm just curious about what concrete experiences medical students would have to develop some of these abilities that you're talking about.
Well, we basically steal some of the experiential learning and also coursework that already exists in business schools and in health economic schools and in law schools that we just haven't had in medicine. And so that's why it's so important to partner, for medical educators to partner with educators from these other disciplines, because they have it figured out. I mean, Tuck knows much better how to educate students in leadership than we do in medicine. And so we're partnering with those experts and adapting, I guess, some of that coursework and some of the experiential learning to medical schools. And then we're developing some of our own little tools. I mean, this is one little example is this checkbook tool we developed as part of this program at Mayo, where medical students actually were aware of the costs, the prices of everything they ordered, you know, and after caring for a patient for, you know, a week or some period of time, they would look at that, and there was a learning, a reflection of, okay, look at everything you spent looking after this patient. Could you have achieved the same or better outcomes without 6 chest X-rays? Maybe two chest X-rays have been sufficient or even better, perhaps. And so some of that is just exposing them to data that they previously weren't exposed to. Yes, sir.
In addition to working with individual students, do you partner with something like the Princeton Hospital to not put 1 or 2 well-educated students there, but to work with the hospital as a system to try to cause this to happen?
Well, absolutely, and I guess I'd refer to the Dartmouth program. The Dartmouth program's a little different than the Mayo program. At Mayo, we focused on medical students. At Dartmouth, they did a little bit of that, but they also focused on, and I think as you saw in their video, sort of senior leaders in medicine. And so you had the CFO from a major hospital as part of their program, or some other senior administrative leaders. And so I think it's important to educate, as you point out, not only the providers of care, but you know, hospital leaders and hospital administrators in these same skills.
Are you doing that with the Rutgers Hospital?
With the what?
The New Jersey Rutgers Hospital?
Now, I've been there 6 months, so I am starting this program, and we will be doing that, yes. Yes, ma'am.
If you could change if you had a magic wand to bring the healthcare system in this country up to some of the other results, like in the UK and France, etc., what are the things that are working against our country to deliver that level of healthcare? Because some of the things that you've mentioned, evidence-based medicine, patient-centered care, these are things that our daughter 20 years ago in medical school was extremely enthusiastic about.
Yeah.
And she's still enthusiastic about them, but they're not bringing the results to the country that would be ideal.
Well, I think part of it is actually culture, right? So it's not science, but it's culture. And some of the things that were brought up in the discussion, this notion that does exist in the U.S. to a much greater degree than in Europe and in Canada, that you've got to do absolutely everything for every patient, you know, bring everything to bear and kind of to combat illness. That's a bit different than in other parts of the world. And, you know, I think we do it too much, and I think there's good data now that we sort of overdo it and actually end up harming patients. But it's very difficult to change that because it's ingrained in our culture. And some of it is, so that's one thing. And I think the other piece is social. You know, really, and maybe that's a little bit outside the bounds of your question, but the social determinants of health are so important, and that's, somebody mentioned politicians, that's where politicians really, and the political system maybe can help us. There's so much more, there's so much impact on health outcomes that hasn't much to do with medicine, and maybe if physicians understood that a little bit better, they could help move the needle there. Wow, I've exhausted all your questions.
I have one question for you, and I apologize if it's unfair or a little premature to ask you this, but since you've been here less than a year. Well, you've come from a private medical school at Mayo to a public-sponsored medical school here in New Jersey. Have you met different challenges here than you were facing before you came here?
It's an entirely different planet. So it's very, very different. And actually, it's one of the reasons I'm here, because as you've probably guessed, I'm very interested in, you know, the changes in healthcare and being able to make some sort of, at a national level. And I realized, you know, spending your whole career at such a unique private institution really doesn't give you a good picture of what's going on, certainly across the country. So I really wanted to learn about, you know, what a public environment was like, what a unionized environment was like, what a much more diverse, frankly, environment was like, and the challenges. And so those are, you know, the challenges are very, very different. There are lots of challenges in both institutions, you know, and opportunities that are very different at both institutions, and they're probably in those categories.
Well, let's thank Dr. Negro for